this system is there is better irrigation at the site of the osteotomy. So with a closed system, here you can see there are studies to show that the irrigation level at the implant site is a lot less when you're doing fully guided surgery, but when the slot gets opened, there is definitely better irrigation. And these are the components. So typically to make a guide, you would need the material that the guide is made of is either PEEK or PMMA. These are manufactured by Hiossen, or even your local labs which have 3Shape software should be able to design these guides for you. You need to give them two basic data points, which is the CT scan, and the second thing that you would need to give them is the scan of the patient's teeth, which could be either with an intraoral scanner, if you have that, or just an impression that they can scan in the lab. There are different drills in the system and tissue punches. So if you're familiar with the regular taper kit of Hiossen, the drill ends are very similar in this system as well. Right, here's just a quick case of a patient that we used this guide for. The patient had a non-restorable number 4, and the plan was to extract immediately and use the one guide to place the implant immediately. For anybody who's done immediate implants, they would know that placing an implant in an extraction socket is always a little trickier than doing it when the bone is already healed. So for the planning part, there are different softwares that you can use to plan an implant case. So this planning was done with the CareStream software, and we took the patient's intraoral scans and superimposed them on the CT scan of the patient. This worked, so this is the number 4 that we are planning to do an implant on. And this allows you to merge the file of the CT scan on the file, merge the file of the scan of the patient's mouth, the intraoral scan, on the CT scan of the patient's mouth. And this will just happen in maybe a second, and here you go. So here you can see the intraoral scan of the patient has been merged on the CT scan, and this gives a very nice tool for you to treatment plan the case. We can do the same thing for the mandible, and this also becomes a very nice patient presentation tool. So when we're trying to explain the patient what procedure we're going to do for them, where is the implant going to go, what size are we going to use, I think it becomes a very nice patient education tool. So the patient feels a lot more comfortable, because every time you do an implant surgery, they are apprehensive. They are kind of scared to go through the surgery. But when you show them the planning that goes behind it, I think the patient becomes a lot more comfortable in doing the procedure. Right? So the same software, we can go and exactly measure what size of implant and how much bone we have available, and plan that entire implant case on the computer first. And then once this planning is done, there was a tool here which we can pick and see what size of implant we want. Here we've done the measurements of the length and the width available for the implant placement, and we can go ahead and select different size of implant from the software. Here, alright, so this is the clinical situation. And that's the guide, which is 3D printed. So typically when the guides are designed, they're designed in different softwares, the most common one being 3Shape. And you can have small windows on the guide to make sure that the guide has seated down completely. Because if you've done great planning and the guide has not seated on the patient's teeth, well, your plan is completely off. So having these small windows to make sure that the guide has seated is important. But once that's in, and once that's in position, you should be able to execute the procedure pretty easily. For implants, typically infiltration for maxilla is
You went to go eat with Sean and
atraumatic
Mark.
extraction. Is somebody here a periodontist? No.
Huh?
So, but in general, as atraumatic
like they left about 20
extraction
minutes
as you
ago.
can do, and place the guide on. So now these drills with the one guide system are unique because they have a metal sleeve on the shaft of the drill. And what that does is that kind of braces against the guide that we have made, and you can drill through it very easily. The other guides, the regular guides that we normally have a metal ring in the guide, and you use that to place one more key in that guide. Has anybody seen other guide systems? Nobel, which has the key, and you basically are taking in and out that key and then drilling through it. It can take a little longer to do that, and also I think the chances of you going wrong are a little more because there are more components that are being taken in and out of the guide. In this, that ring that is placed, the metal ring that is on the guide is actually a part of the drill. So this drilling becomes a lot simpler than any other system. And like you say, so every time you're drilling, just make sure that the guide is seated down. And once, I think this was a 4.0 implant, and for this, I think we need three drills to be able to execute this surgery. That's the Hiossen implant with the carrier, and you can get a pretty good torque. Yeah, so this was about 30 Newton centimeters, so I think we had a good primary stability. This is a simple technique for grafting during immediate implant placement. So that's the membrane that's held by the healing abutment, and we can tighten that membrane in position and then graft in the jumping area, which is the gap between the osteotomy, between the extraction socket and the implant, and we can insert some bone graft in that area and then suture it up. So that was the implant surgery at the time post-op, and this is about 1 week post-op healing for the same patient. And this was at the time of the implant surgery. So we could execute this in less than 5 to 7 minutes because the pre-planning was done and everything was executed at the office as per our plan. Right? So typically the process to make a surgical guide would be at the office we would do the CT scan, or if you're referring out a patient for getting a CT scan, we need the CT scan and a digital model of the patient's teeth. So you could get that with an intraoral scanner, or you can just take alginate impressions, pour the model, and send that model to the lab. And they should be able to make a guide off of that from you, for you. Again, the same thing, imaging center, clinic, and then typically before fabricating the final lab, the lab would actually send you the plan, and you should review it and approve it to see if the implant angulation that the lab has planned is good, and you will be clinically be able to execute that plan. All right. So that was my quick presentation. If you have any questions about the system, would be happy to answer, and I'm sure the staff here should be able to help you guys.